Hey guys, this is Dr. Sarah Heron from Seattle, Washington, coming at you live. This is the PT on Ice Daily Show, and we're going to continue today talking about hip and hip impingement and sort of my process of how I treat these folks. So if I'm looking at this camera, this is Facebook and here's Instagram. So thanks for following and we'll get started here. So last week we talked about femoral head positioning and how an anterior position of that femur in the socket is really sometimes what we can correct, right? So we're not going to be able to correct those bony impingement processes. We're not going to be able to change the shape of the bones. That's how people are made. Okay, but what we can do is address this idea that the femur is likely sitting forward in the socket. Last week I talked about how that is often due to our sitting posture. So when folks are sitting, yes, they are in hip flexion, but truly they are not sunk into the socket and centered here. They are really more tipped back. They're typically going to be sitting, sacral sitting, right? Sort of tipped back onto their tailbone. So relatively, that femur is now punching forward. Okay. Similarly, in standing, most of the time, people lock out, right? So they lock out, hanging on their ligaments, right? And that femur is now blowing forward. So again, we want to just address this with our patients. We want to educate them about that. We want to assess that. Okay, so I often will do that in standing. I will stand behind them and I'll stabilize them a little bit by leaning into their body. Okay, so I kind of put my shoulder right up against their, usually more their back, but just for demonstration purposes here, I'm up against his pelvis, but I'm going to have my hands right on the front of that femur. So I'm right on the femoral heads here. Morning, guys. So as I palpate, this does take a lot of practice. And I have had some success with patients who can kind of feel it on themselves. But where I really feel the forward nature of this positioning is when they go into single leg standing. So I'll have my fingers here and kind of, I'm not stabilizing, but I am palpating enough that I can feel that bone. Okay, they go and shift onto one leg. If they can center that femur well, if they're controlled, I shouldn't feel any movement. If they're not controlled, I literally feel the bone come pushing into my hand. Okay, so if I am putting my hands here and they're shifting over, I'm gonna feel that femur come into my hand. Okay, so that's really helpful. That's just helpful for me to know that that's a problem, to know that they do have this micro instability and we need to work on that, right? And it's helpful for the patient to understand because then that becomes more clear to them that my femur is forward. I need to work on getting that back. Okay, so remember our goal is to restore that centered position. So that's our goal before we can really even start strengthening their glutes. Their glutes are going to hold that position for us, but if they're forward, they're not going to have very much success. So I think that's where I see some of the disconnect with patients who are having good care, we would think, but they're not getting any results, right? So they're working on all of this glute strengthening. Maybe they're stretching, maybe we can take that away, but they aren't feeling like their glutes are actually doing the job. Okay, so we got to get that bone centered back in there, that femoral head. Okay, so before we talk more about that, I want to talk about a concept I call bull's close. So you guys might hear me say this. Basically what I'm talking about is rib cage down. For these patients, they do not typically need to be worrying about their bottom bull. So I describe this as the pelvis is the bottom bull. Okay, and I know if you guys are on Facebook, you can't see the rib cage on my model here, but the rib cage is an upside down bull, right? So we know that those should be matched. Bull's close, okay? Most of our patients are going to be, most of our hip patients, I'll say, are gonna be kind of flared in their chest, and as a result, they often try to tuck under. So I jokingly call these their fake abs. Okay, their TFL, their hip flexors are trying to stabilize them, but what they really need to do is use their abdominals to bring that rib cage down. And until we can restore that position and get them stacked, bulls closed, then we cannot truly hinge from the hip when we're trying to do things like bridging or a standing hip hinge or kettlebell deadlift, any of that. If they are flared in through their rib cage, they're going to be using their back. Okay, so let that sink in for a second. If they don't have that stacked position, that bulls closed position, and most typically it's ribs down for them, okay, then they are not going to be able to correctly hinge from their posterior chain, from their hip joint. Okay, what they're gonna try to do when you say bulls closed is they're gonna go, oh my gosh, my camera, they're gonna go tuck, okay? So we're gonna talk about that on the table. I'm gonna use a bench today, but in standing, that's gonna become really important. So next time when we come back, I'm gonna bring you into some standing exercises and we'll go through how to keep those bulls closed as we work on hip hinging. Okay, so let's review the TFL down training. So we talked about that last week. We'll just touch on it quickly because that's really the number one thing. If we can turn this TFL down, then we're gonna have some success with getting them to start to center that femur. So again, I use a non-stretchy strap. This is my yoga strap. And I'm gonna have them on their back. Now we can start talking about ribs down for them. But what I'm having them do is literally a bicep curl. So they're palpating their TFL, they're overworking muscle here, and they are doing a bicep curl, okay? They're teaching their hip that this is a safe position to go into, that they don't need to grip and use that hip flexor to do it, okay? So several reps of that, at least 10 probably, getting them working on that. Then we want to work on psoas up training, right? So that's going to be really tricky. If they don't know how to turn off their TFL, they aren't really going to be able to correctly engage the psoas. So you may have to work on that and some other things for quite some time, but I will segue into this exercise. You just may have to hold off on it for a while or do a modified version. So this is now a stretchy TheraBand, and I use a green typically to start. Most brands, the green is the more firm, okay? And this is now going to be an assistance band, not a resistance band. So we're working on eccentrically lowering the psoas, okay? So we're not gonna be pushing through this band. We're gonna use it as a sling to support the hip as we come down. So if I'm having right hip pain, I've turned this down, I've learned on my core control, I'm working on centering that femur. Maybe my therapist is working on some soft tissue work, some mobilizations in through here that feel good, that aren't stressful to my joint. Now I'm gonna take this band, I'm gonna bring it around my shin and crisscross in the back, okay? So again, on the shin, wrap around and crisscross. That's gonna give me a little bit of support. Now, my other leg is up on the table so that I can have some lumbar support. Okay, so I'm gonna just allow them to eccentrically lower. I'm bringing my hands with me because I'm not pushing through that band. That would be booty, right? Instead, I wanna load eccentrically in the front. Here's the trick. They need to center their femur, and most of them are gonna kind of like this position, okay? And when we go into external rotation, that head, just like in the humerus, it's going to shift forward, okay? So I need to get them to push into internal rotation. Now, a lot of them don't have internal rotation. I know I have 0 degrees of internal rotation, but I can still isometrically push into internal rotation. So I'm pushing my foot toward the camera, okay? If I'm the therapist, I often put my hand here. I'll even put my other hand on the inner knee so that I can get them to push into internal rotation, okay? So they're giving me pressure into that position, centering their femur, and now they're gonna eccentrically lower, okay? Now, oftentimes, they're gonna complain about a clunk, okay? And that's why we do this exercise, and we wanna avoid that. We don't want that clunk. what I'm thinking is happening in that clunk is that femur is driving forward. It's not centered, right? And the psoas is strumming over it and causing that plunk. And it's not a click, you guys. You know it when you hear it. You know it when you feel it. It is a plunk, right? So we want to center, center, center. Usually, if they're really pushing into internal rotation, we can get that to go away, or we can limit it. So I only have them go as low as they can, and then if they feel like the clunk is coming on, they come out of it. Okay, and typically this is challenging enough that we're looking at like 3 sets of 5, okay, something like that. So again, we're eccentrically loading. We're not pushing through this band. The band is supporting us. This is a sling, okay? And as they get stronger, this can be a lighter and lighter resistance band. Eventually, they should be able to do an eccentric lower with some internal rotation effort, not necessarily position, and then they are slow lowering, clunk free. Okay, now as a person with hip impingement, I used to always get clunking with like say V-ups or knee ups on the rig in CrossFit, toes to bar. I get clunking, right? Somebody who's not familiar with CrossFit, bicycle abs, anything where I'm taking my legs and lowering them, especially with a long lever, like a straight leg. So I can make that go away if I turn my legs in. Even just the effort of my muscles contracting, right? Because I don't have a lot of internal rotation, so they're not going to go that way, but that can help, okay? So we're centering that femur and then we're loading. Okay, so that one might take a while for your patient to feel ready. But it's a good one to start practicing on your colleagues and make sure that you can teach it and try it on yourself, because that's a really important one that I think gets overlooked. Okay, I want to talk about 2 more centering activities, then we're going to stay on a flat surface, so they're going to have some support here. The first one, or the third exercise today, is rock backs. So I'm actually going to come onto my bench so you guys can see me, but probably do it on the floor. Okay. So in this position, I am going to have my bowls closed, okay? Again, my ribs are down. They're going to often want to go into child's pose. And you can see I'm rounding my back. My pelvis is posteriorly tucking. And what that's gonna do is not center my femur, right? My femur is now forward. So I need to think about sit bones lifted, kind of toward the ceiling, right? So I'm centering here. If they're getting pinching, let them go into a little external rotation by separating their knees, okay? And we're not gonna go through that pinch, but we need to teach them that this is safe to go into, okay? We need them to understand, we need their proprioception to be on board with, this is safe, this isn't pinchy, okay? A lot of times what can help here is keeping this relaxed. So I cue, use your hands, push. Use your hands to push back so that you aren't gripping with your hip flexors. We're not pulling ourselves into this position. We are merely folding at the hip. Once they can figure that out, once they understand the difference between gripping and folding, oftentimes they can get into that position. Okay, that's a really good one. So I just call those quadruped rock backs. That's a Shirley Sarman technique, okay? And a lot of my theories about hip positioning come from her philosophy, if you guys want to read up more on that. All right, finally, we're gonna do basic bridging. So, do I love bridging? No. Do I love clamshells? No, they are not functionally relevant to much of what these patients are doing, but it's important for them to learn these concepts, okay? So with bridging, I want to see if you guys can see the difference. When I bridge, right now, I'm in a flare. I'll take this off so you can see the color difference. Okay, so if I'm kind of flared in my rib cage, and then what most of these patients are going to do is they're going to roll up. So by doing that, by doing this tuck here, I'm now engaging my fake abs, my hip flexors, right? So I want them to come back out of that. I cue tailbone down, ribs down, okay? Ribs down, this can take a long time for them to figure out. So ribs down without tucking. Tailbone down, ribs down. They need to exhale oftentimes. Then I can truly hinge at my hip and squeeze my booty. If I don't do that, if I'm flared here, I'm gonna probably use my quads and my hip flexors and continue to shove that femur forward, okay? So that's a couple tools for you guys to try. Next week, we're gonna get them standing. But remember, our objective first and foremost is to center that femur back. And again, we can use manual therapy to do that, but a lot of it is just motor patterning. So we need to turn that TFL down, up train the psoas when we're able, and start getting hip hinging. Meanwhile, we are maintaining this bowls closed position. Okay, give us comments. If you guys have any feedback or questions, we're happy to answer. And good luck. We'll see you next time for our standing exercises. Have a great Tuesday, and it's almost February. See you guys. Have a good one. Yes.